where we were talking about the regression in hospice care that we've seen in the last number
About
of
what
years.
happened to her before we came to you
Yes, I
guys?
wanted to mention that because you're talking about a very positive hospice experience where you were given back the ability to work with her and make decisions, and she guided you and told you what she wanted, and we had the right medications and the right planning and the right discussions. But there's
And
also
the right information that we needed
Yeah.
as we went along. A lot of I didn't understand, but understood as it progressed. But before, once we made the decision that we wanted hospice, I called the hospice that had been recommended by the hospital. And they came out and assessed her and left, called me a couple hours later and said, she's not a candidate for hospice. And like she was outside of me, I'm almost blowing a gasket because I couldn't understand how somebody who was terminal wasn't a candidate for hospice.
There is no cure for ALS. It is a terminal diagnosis, and it is immediately qualifiable when it comes to hospice services. For them to say that she didn't qualify, that is
Told me I didn't understand hospice. So
I will say there are criteria, but they're antiquated criteria. You know, really, the truth is gauging the patient where they are at the moment, and she's certainly qualified.
she absolutely qualified.
It's really about prognosticating. But in your case, you were going to mention that there were maybe
but
some
the
other-
interesting part here is why I think that it's important to say why she was not a candidate.
So-
and please tell us why.
So the reason that I later found out why she was not a candidate, although she was she was on the Trilogy ventilator, and that cost a lot of money, and they didn't want to have to pay for it. And when I talked to people at the ALS clinic, I called them and I said, we got a problem here, because we were still trying to figure out how we're going to afford this. And the nurse practitioner says, oh, we find this all the time with ALS, that people apply the hospice and the hospice denies them. And I said, I thought that they couldn't deny somebody who was in need. She said, oh, it happens all the time with ALS. She said, if there's anything we need to fix about ALS, it's that, which I agree. It was a horrible experience. And I was lucky to find your hospice, a wonderful woman who kind of shepherded me through the process. But it was because of money that they would not accept her. And I told them she wasn't a candidate for their hospice anyway, because I wouldn't have
What
her
a
there.
great answer you gave them.
I know that's a very good answer.
Yes.
Yeah.
Yeah. Well, I know.
So
that
we just to make sure everybody knows. So from that afternoon when she was denied, when I called
Debbie.
Debbie.
who I don't know what role she's in, but it was after hours, and she just kind of took me by the hand over the phone virtually, and she says, we will get it taken care of. And from that moment on, I knew I was taken care of, and we were going to have what we needed. But it would have been a very different experience.
Well, I think so. You think about the fact, I mean, what would that,
What would you have done?
Exactly. What would you have done? How would you have slowed things down if you don't have the modalities or you're not offering them to people?
Right.
I mean, it changes prognosis and mortality enormously.
Right.
But it's also having someone experienced and knowing. We've run into things where people think this is very different, but we've run into circumstances where people think by just adding more and more and more, you're going to actually just avert death or keep things going. And this was very different. This was actually a palliative measure that needed to be in place for her to actually be comfortable and not rapidly decline. Very different trajectory, very different mindset.
Yeah. We really kind of happened on the Trilogy ventilator mainly because my colleague, I said, we got to do something. And, of course, we didn't know she had ALS. And we started the ventilator. By the time she was diagnosed with ALS, if we took it away, she wouldn't have survived many weeks at all. If any, if weeks, she wouldn't have survived.
Yeah. Do you think you got good guidance along the way? I know she wasn't diagnosed right away, but in terms, do you feel like you got good guidance from, those you spoke to about ALS? Is there enough education?
So, no, and I would not ever say anything to take anything away from the ALS folks at Emory. They were wonderful. So I'll tell you our experience, and then I'll tell you what I would think that would help. Our experience is we were diagnosed. She got the diagnosis on August 23rd, 9 o'clock in the morning. She was end stage, so there was no need to do any follow-up. Pretty much, there weren't any clinic visits, follow-up setups. There really wasn't anything that was done. And like I said, I don't want to disrespect or diss any of the ALS clinic because I have greatest admiration for them. But I do think that the end stage of ALS, the very end, it was not until I met with the clinical nurse specialist that was in the hospital, and she called over one of the nurses from the ALS clinic who was wonderful and came to her bedside and sat and actually explained to Sylvia, this was in October before she died, explained to her in great detail. She says, this is where you're at, and this is what it's going to look like on the other side, if you get a trach, if you don't get a trach. And it was very clear. And she said, and they were, that happened because I had asked for it, and because it was two factors. My clinical nurse specialist friend was asking for it, but I needed somebody. I'd been begging for somebody to come over and talk to her. But she was able to really paint the picture of, do you want quantity of life or do you want quality of life? And once she understood in a very raw clinical picture, you won't be able to move, you won't be able to talk, you won't be able to breathe on your own. You'll have to breathe. When you breathe through the trach, it's going to be like breathing through a straw, so it may not feel the same. I mean, it was really raw details. She says, I spend most of my life talking with people. She said, it would be no quality if I wasn't able to communicate. And at that point in time was when they were able to say, she said, say no, it's trach. But then we had, what do we do from here? And that wasn't ALS. It was, and I think if I were to encourage or invite ALS people to do more, it would be to, and I hope they don't shoot me if they hear this podcast, is that really helped to understand that last piece of the process, because we had no idea.
Well, it was a small symposium for ALS, and I was really, I wrote something about it because I was very struck by the fact that everyone there wanted to talk about cure. Not one person, maybe I wasn't interesting enough. Not one person wanted to ask about dying, and I thought, but that's a guarantee in this at this point. Mm-hmm. We're not talking remotely near cure. Now, I admire those who are searching for that, but that's not where we are. Mm-hmm. And not having a real discussion, as we're trying to do today, about how you pass away with a disease is exactly the problem that we face time and again. And as you said, we get so much resistance. You laugh about it. There was maybe some small resistances along the way because of negotiating, which I'm okay with. That makes sense to me. But we get large resistance in terms of accepting. Mm-hmm. And that's very difficult. But I think especially for ALS, not knowing that, it really translates to a very very poor outcome.
Mm-hmm.
You know, you wonder how many people. I've had other patients, and we've done a good job with those patients, but it's.
Oh yeah, yeah.
It's a constant education. It has to be. And many times it doesn't want to be, they don't want to hear it. Nobody likes to talk about death. And I know that, but I know also how important it is. I always used to tell my patients in the field and also the caregivers, it's better to have a plan and already have it set in place and put aside than arrive at that moment
And not
have a plan.
That's exactly right.
And where we see that a lot is with medications. No, we don't want to take morphine. No, we don't want to do this. No. And all these options that we are trying to provide, they are not taking advantage. And then we arrive at that moment. And it's like, what do we do now?
Right. So I think there really is, there's a piece of context here. Because if you look at when we left the hospital in October, she decided that she was not going to get a trach. We intuitively knew it was not going to be a long time. We didn't know how long, but we didn't know it was going to be really as quick as it was. I talked to her. I said, do we want to start hospice care? Because the hospital was encouraging us to start either palliative care or hospice care. And she was resistant to that. I said, well, let's just start palliative care. I said, that doesn't commit. And, understanding hospice is a big deal because even me, having been exposed to hospice in my past, I still had misconceptions about losing control of the care, actually. Losing control. So the thing that threw me was, and this, like I said, I'm a nurse, I should know this, but I didn't. But what was hard for me was, okay, if she gets something acute, like a UTI, are we going to treat that? My assumption would be yes, but I wanted to know for sure. Mm-hmm. If we're going to do, it's where do you stop treating things? And what I wanted was to treat her for the things that which would prolong her life and allow the quality. Mm-hmm. I didn't want anybody to take anything away that would shorten that process. Mm-hmm. I wanted anything that would do with lengthen that process, but I didn't want anybody, and it was worry for me that some of the things that I was worried that would be taken away, that we would do something that would just shorten things unnecessarily.
I hate to interrupt. You just hit the nail on the head. You just said exactly. It takes a lot of experience and time working day in, day out with mortality. As with anything in medicine, you end up over time accumulating experience. We have gotten to a place now where you can watch a situation and gauge where they are. Mm-hmm. And with that, I'm pretty good at this point at saying, this is something I think we can treat still. Mm-hmm. And this is something which is irrevocable at this point and a process issue. But that takes time, and you would be amazed at the lack of faith and trust that people have in honoring you with that. They're very, I don't think there's any other field in medicine, because I worked in the hospital for a long time. People disbelieve what you're saying day in and day out because of that very issue. They think that they know better if we do this, this, and this, or they'll get other opinions. And then they'll say, well, if we do X, Y, and Z, of course we're going to be prolonging life. But they don't realize they don't have that global picture and that perception of mortality that we do, which is a very different framework.
Yeah, so, I want to give an example of that because UTIs, yes, we treat UTIs
Yeah.
in hospice. Do we prescribe antibiotics? Absolutely. Do we take care of wound care? Yes, we do. We do many of the modalities. But we also have to take in consideration where that patient is at in that continuum. So because one thing is prescribing antibiotics because we know that they might be a UTI, yet the patient already have started in that transition,
Right.
and is unable to swallow, and the breathing patterns have began to change. So understanding that, yes, we treat for those things, but also please accept that we also look at patients as a whole. And if another process has started to begin, then we have to see where things are at and see if that would be the best action.
So I'll give you a perfect example for that, because toward the end, you said stop giving her G-tube, feedings through the G-tube. And just for a brief second, I kept thinking, are we ready to stop giving feedings through the G-tube? And then you explain what was happening in the body and how that actually can make it worse and interfere. So that explanation helped me, but I don't think that people really understand that if you play your cards right, and like I said, that was my worry. We had to get home. We had to find a hospice, and I had to find a hospice that I was confident that would help me. This is what it was. Help me, help her live as long as she can with quality. And help her die with dignity. Don't make it any faster than it has to. Don't do anything that's going to make it go faster. And that was, with the Dilaudid, give her this amount, we gave her half. Because we kept looking at, if you get that amount, you're going to be sleeping, and process is going to speed up a little bit. I mean, that's exactly what it was. It's really this balance of getting to that end goal, which allows her to be on the planet as long as she can be, as long as she wants to be, and as long as she has quality. But the other piece of that, and like I said, the point of this is context. When we talked about hospice in the hospital, neither one of us could talk about it. We couldn't. Neither one of us could talk about it. The most we could do is talk about palliative care. But I will tell you that when we got home, and all the care was mine, not that it hadn't never, because I cared for her in the hospital, then I started going, how am I going to help her through this? And I was the one that said, we got to do hospice, and here's the reason why we got to do hospice. And if you look at a general population of people, people don't want to talk about dying. People don't want to talk about hospice. And I didn't want to talk about hospice until I wanted to talk about hospice, which is when I needed it. So how do you put into the environment and educate people about what hospice offers for people, where they can put it at the back of their folder and know it's there so I can come back to it when I need it? I mean, I'm talking about an analogy. Put it to the back of my brain so I got it there. Okay, I understand why I need it, understand what it does, and when I get ready, I know where I can go.
I think this is part of why we are here, because that education piece, hospice is not in the 11th hour. There is so many benefits to starting hospice early. And how many times, Dr. Pujari, have we discharge a patient because they have gotten better? They have not been, they might have a condition, but it has become more chronic. And we are good at doing that also, but they benefit from the hospice support, from an interdisciplinary team, from the chaplain, from the social worker, from nursing, from Dr. Pujari being so honed in on their medical care. That is a benefit, and you don't see that out there in hospice. If we do hospice right, and I know we do hospice right, then that is what you should be expecting.
Well, and I would also say I want hospice to do more, and I want more hospices I want more hospices to come around to, I kind of said this in an introduction to this podcast, to elevate the specialty. This is not an afterthought or an area where it's just a kind of a segue from prior care. And we get that quite often. It's something where over many years of dealing with patients who are passing away and all nuances of that on very tough cases, clinically tough cases, where we may have very intractable terminal agitation, or we may have a bleeding issue, or wound care, or having to coordinate care, or we've come up with the ideas of managing infections and at what juncture and what antibiotics. And it gets very nuanced and it's very clinical and very rich. So, with all of that, I think we need to see hospice as an elevated specialty. And right now, the way hospice is operating is almost on a shoestring budget and trying to relegate all forms of dying down to a very simplistic model, which, as you're saying, that runs counter to a simplistic model.
Exactly.
You can't say, I'm not going to offer a trilogy machine to a patient like Sylvia. Or if I had said, well, there are no options for subcutaneous or running a drip. Or we're not going to offer these nebulizer treatments, or we're not going to help you manage the gastrointestinal manifestations.
Every one of those, if you had not managed, would have shortened that process.
I think so. And
I know so.
Yes.
Every single one of those, if we had not managed, would have shortened her life. If I had a podium and I could speak to people in ALS, what I would tell them, and Evelyn, I think it was you that said to me, I don't remember actually, but I think that was you that said something about, I don't remember the words, but what a difficult disease to die of is ALS. I mean, I don't know if I think it was you, but somebody said that to me, and it really caught my ear, because of all the diseases you can get, this is one of the ones that can be, I'll just say it, horrific.
It is.
Horrific.
It is to be trapped in your body
and not
with all your functions and just be trapped in your body. It is cruel. It is horrific. It is horrific.
And that caught my attention. And if I were to speak to ALS caregivers, is that it's hard to come to the point where you want to do hospice, but just remember that, because I know there was a couple of people who have died of ALS since Sylvia died. It was and had no one there, no care. I would say, you don't have to dwell on it today. You don't even have to figure it out today. Just know that when you're getting toward the end, there is a journey and a body of work, I'll call it that, to enable a person with ALS to really live until the end and not have to suffer that horrific death. Like I said, I've heard of 2 people, and it just breaks my heart to know what they went through. The second thing is that one hospice is not the same as other hospices. If I were to be able to speak to the myriad of hospice companies out there, is I do believe, in my minimal experience, that many hospices have lost their mission. What are we really about? And if the mission of hospice is really dying with dignity and grace, there's a lot of places out there have forgotten that. And you did work with us with every nuanced problem that came up to address it. And it's not just knocking somebody out and letting them die at the end. That's not that's not what I think. I think what's possible with hospice is a fantastic opportunity to enable people to really, like I said, I keep saying it over and over again, to live as long as they can and as long as they want, and die with grace and dignity.
I think that's actually, we need to just have conversations about mortality in general and not consider it a negative.
Absolutely.
It's the starting point. Learn to be open. You would be, I mean, all of us collectively, you talk to friends. If I say what I do, or if I'm talking about, just mortality in general, everyone always kind of, there's a shift, or people get very sad, and I think, no, I think that there's so much to discuss.
Oh, yeah.
And then, from there, I personally believe mortality impacts, the way we live also, right? It kind of reframes your existence when you're mindful of mortality. I think that's what it's useful for. So I think that something like this jumpstarts the conversation. I think the other thing I wanted to say is something about Sylvia's case, just to kind of pull everything together. Her passing was incredible.
Oh, gosh, yes.
Would you like to
Even
speak
the
about
day.
that? Yes.
Even the day.
I
I don't know
we
if I can talk about it.
If you're able. I mean, I don't want you to feel...
So, it really was quite miraculous. She had, so I don't want to take too long to tell you the story, but I'll tell you the story. So prior to, after she had already we started with the Dilaudid and she was sleeping. I thought she was sleeping a little bit. So I went to go in the kitchen. This is answering more of your question than you ask. But, and I was ordinarily I was sitting there and eat my lunch with her, but she was sleeping, so I was eating the kitchen. By this time, she couldn't hardly write, and she could hardly get out any words. And she was upset, and I was trying to figure out, what are you upset about? And really trying to help her. And she said she felt alone because I was in the kitchen and not in the living room where her bed was. I said, well, we'll fix that. We had moved out her recliner chair. We put it, I said, this recliner chair is where I'm going to be from now on. And so I stayed there with her. I said, it was facing her. She could see. I could hold her hand. I said, you're not alone. So then she got to where we did the drip. And the drip, she was really I was asleep, quite asleep. And I stayed with her. I slept there up until about about 3 days before. And before she died. And at some point in time, and this is probably getting way off the topic, it was hard to sleep in the chair, but I really felt like her spirit had left her body. And so I laid down on the couch. I slept on the couch beside her until the end. I woke up Christmas morning, and by that time we had turned off the monitor on the trilogy, so we weren't even paying attention to how many breaths she was taking and everything. So I get up on Christmas morning, and something just told me, look at that monitor. And when I turned that monitor on, she was drawing one breath out of 12 that was hers. And I knew that she did not want to be prolonged on that. So the hospice nurse, Caroline, we had invited her over for Christmas breakfast because she was going to come by anyway. So come by, have breakfast. So we had breakfast, and after breakfast, I told her, I said, we got to turn the ventilator off. And so she called you, and we started the process of decelerating the care over, and slowed down her oxygen, and slowed down, eventually took her mask off, and wasn't long. She looked like she was beginning to scrunch up her forehead a little bit, and I told Caroline, I said, we need to give her something more. I said, and so right then she gave her some more Dilaudid, and it was just very peaceful, and She passed on Christmas Day, which was quite spectacular. And it was very beautiful. I don't know if that's what you were asking.
It was what I was asking. I remember thinking that was pretty amazing.
It was.
And I think the whole process was very peaceful. Well,
it was.
Anything?
I think you couldn't finish it with a better ending of how everything summed up to that moment.
The only thing I would finish it with is if I could get out on a billboard, tack myself to a billboard on the side of the road, say, you guys got to figure this out. ALS people, you need to plan. It is the difference between, the difference is so significant I can't even speak it. In hospice companies, those who don't understand what opportunities that they have, and they're just doing what they do to get by, hospice companies, you have a tremendous opportunity to impact not only the person who's dying, but my whole family. Everybody was there with her. My kids walked through the dying process with her.
Actually,
We tacked myself to a billboard.
well, walking through the dying process, I wish more people had an opportunity to walk through that process. Mm-hmm. Personally, in my own story, I have, and I know that that's actually what shaped me and molded me and kind of set me on my course. It instills a humbleness in you where you say, we are mortal and dying serves a purpose. And we need to focus on that much, much, much more. And it's not a morbid exercise.
No.
It's actually an exercise that gives you quality.
It is the most beautiful process that I've ever been involved in. So.
Well, I appreciate very much both of you coming today. I think this was a very good conversation. Did we leave anything out? I don't
Not that I can think of.
Anything from your standpoint? I know you've been through a lot. We'll have more conversations too.
Absolutely.
But
I think that this was very much needed. I think that the advocacy for the ALS patients, we know that it's a terminal diagnosis. We know that that they can receive hospice services, and finding that perfect place to care for them, and just continue to spread the word that there are options. There are options out there, even though it is a terminal diagnosis.
There's, like I said, boundless opportunities that hospice can give to people.
Yeah, if they do it
step
right.
up to the plate and do that.
I
Yes.
feel that. I feel very passionate about that.
I absolutely passionate about it.
Thank you so much for joining, and we hope you'll watch this and other podcasts or spread the word on this and other episodes. And it will drop every Tuesday at 3. And then please see links below. And thank you. Thanks for watching.